And our first speaker this morning is Dr. Steve Greenberg. Steve got his bachelor's at Princeton, his medical degree at Harvard. He got a master's degree at MIT. He was an intern at MGH and then a resident fellow at UCSF. He was associate professor at this time in neurology at Harvard. He's attending neurologist at Brigham and Women's Hospital. He's won an Excellence in Teaching Award from the Partners Neurology Graduating Residents. His present grants have to do with dermatomyositis, inclusion body myositis. He's written 8 book chapters on muscle disease, and he's going to talk today about inflammatory myopathies. Steve.
Okay, thank you very much again for inviting me to this meeting. I'm certainly used to speaking at a lot of neurology meetings, and it's refreshing to not see as many bow ties out there, which I'm accustomed to. So thank you again for welcoming to your group, and I'm delighted to be here and talk to you. So my disclosures are that I have a sponsored research agreement with MedImmune Incorporated, now actually MedImmune LLC, for research support. All the data that I'm discussing here was obtained prior to that sponsored research agreement. And I've also served and am serving as a consultant for CP151 and one other trial design at MedImmune. I'll discuss this trial in a little bit more detail. So the inflammatory myopathies, as you know, are a diverse group of diseases. There are 3 main categories that we think about, and those are dermatomyositis, inclusion body myositis, and polymyositis, but there are also other subtypes, and we struggle a bit in terms of how best to categorize these diseases. Dermatomyositis and IBM are very distinctive diseases. Dermatomyositis is a disease of skin and muscle, but also sometimes other tissues, particularly in children. The muscular manifestations include proximal weakness, so these are weakness of shoulder girdle and hip girdle muscles, hip flexion, quadriceps. This disease generally responds to chronic treatment with immunomodulatory therapies such as corticosteroids, but there is some variation. There are some patients who respond quite readily and others who are quite refractory to treatment. Inclusion body myositis is a very specific disease, and it's distinguished clinically by a very specific pattern of weakness with preferential involvement of finger and wrist flexors as well as quadriceps muscles. Particularly the finger and wrist flexors, these are unusual muscle groups to be affected by dermatomyositis or polymyositis, so it's a very important clinical clue to making the diagnosis of IBM. Many of the patients we see have been previously diagnosed with polymyositis and get referred to us after years or a year or so of treatment with corticosteroids to which they remain refractory.